Good evening, everybody. Welcome to the journal review, journal scan session of Image Group. As you understand, this Image Group is part of the Indian Myeloma Group, and we have an august audience today with Dr. Shaji, Dr. Pankaj, Dr. Uday, and Dr. Hari, and many others who have formed this group a few years ago. And as part of that, we wanted to conduct a journal review meeting where we could critically analyze and inculcate a sense of critical thinking among the students who are passing out as hematologists and medical oncologists. Towards this, Uday has worked really hard in getting this group together and getting all of us together. And today we have reached that point of reviewing the journals and critically analyzing them. So we have one journal which we will be discussing as journal review and critically analyzing that. And there will be a journal scan where one article is discussed, and Uday will talk about that a little later on this. So without wasting much time and pleasantries we have gone through, we will be hearing from Dr. Shaji, Dr. Pankaj, Dr. Uday, Dr. Hari, and of course, Dr. Velu Nair has just joined in. He has been a big support for this. Welcome, sir. You're muted, sir. Yeah.
Thank you, Joseph. I've been there from the beginning, but I was muted.
Okay. So over to Dr. Aditya, who will be talking to us and critically reviewing the first journal article on the determination trial. Aditya is working in PGI Chandigarh as a pool officer, and Dr. Pankaj has chosen him as the first person to start this journal club. Over to you, Dr. Aditya.
Good evening, everyone. Am I visible, and are my slides visible?
Yes, we would like to have your face also, Aditya. If you can switch on a camera, please.
Yeah, I hope I am visible. So I stopped video because of a shaky internet connection here. Okay. So good evening all. So first of all, I would like to thank the Image Group for giving me this opportunity to discuss the today's journal club. And today I will be discussing the study titled Triplet Therapy, Transplantation and Maintenance Until Progression in Multiple Myeloma, popularly known as the Determination Trial, which was published by Paul Richardson and colleagues in New England Journal of Medicine in July 2022. So as we know, multiple myeloma as of now remains an incurable disease for the majority of the patients, and we see frequent relapses during the natural course of the disease. Achieving a deep and durable first remission is an important therapeutic goal, and autologous stem cell transplant remains a part of this treatment approach, which allows us to enable to achieve this goal in majority of the patients. Having said that, it is known that attrition takes place at each relapse. Every remission is precious, and we know that not every patient will receive every drug which is available for myeloma. Moreover, the optimal use of triplet induction regimens, transplant, and maintenance continues to evolve, and the overall survival in the last couple of decades has improved from less than 3 years in late 90s to now 8 to 10 years for the standard risk myeloma patients. So if we look at the current treatment paradigm, so when we approach newly diagnosed multiple myeloma patients, we segregate them into those who are transplant eligible versus those who are not eligible. For the transplant eligible patients, the standard treatment approach is induction therapy with a combination of novel agents, followed by consolidation based induction, followed by continuous therapy and maintenance if they develop any intolerable side effects. So the journey of stem cell transplant actually began in 1983, and this is the first paper which was published in Lancet in 1983 by T.J. McElwain and Paulus, where they demonstrated the role of high-dose intravenous melphalan in multiple myeloma patients. And the 9 patients who received IV melphalan all responded to therapy. Subsequently, in late 90s and early 2000s, multiple trials, mainly led by IFM group, actually established the superiority of autologous stem cell transplant in multiple myeloma in terms of overall response, event-free survival, and overall survival. So before the advent of the novel agent era, the standard approach used to be 4 to 6 cycles of chemotherapy, usually transplantation, and this approach was
Aditya, you can switch off your video.
they have excellent overall response rate, almost reaching 100% in the upfront setting. There is now evidence to support high MRD negativity rates when we use triplets or quadruplets in induction. And therefore, these novel agents are challenging the role of autologous stem cell transplant in multiple myeloma. Another factor which comes up when we analyze the trial data pertaining to autologous transplant in multiple myeloma. So the initial trials which were conducted time used to be close to 3 years. So even with the shorter follow-up, the OS benefit could be demonstrated in those trials. There have been multiple retrospective and prospective studies which have tried to answer the question of frontline versus delayed autologous stem cell transplant in newly diagnosed myeloma patients. So this was the SWOG study, which was published in JCO in 2006 by Bart, Borloghe, and the colleagues, which showed no overall survival advantage of early versus delayed transplant. A similar study published in Blood 1998 by Forman et al. Also showed no benefit. And there was a French trial known by SAM protocol, which was actually an ASH abstract in 1996, and it also showed no overall survival benefit, and this trial was never published. This is the retrospective analysis of transplant data from the Mayo Clinic from 2001 to 2008, where 290 patients receiving doublet induction undergoing early versus delayed transplants was studied, and there was no significant difference in the time to progression and 4-year overall survival between the two groups. Coming to the year 2009, when 2 parallel randomized trials were actually conceptualized to answer the question of early versus delayed autologous stem cell transplant in the context of RBD induction. So the first one was IFM 2009 trial, which was published in 2017 in New England Journal of Medicine. So if we look at the study design of this trial, so this trial randomized 700 patients from 2010 to 2012 into 2 arms, the RBD alone arm and the transplant plus RBD arm. So in both the arms, the patients received 3 cycles. Subsequently, the patients in RBD alone arm received 5 cycles of RBD followed by Len maintenance for 1 year. In the transplant arm, the high-dose melphalan followed by autologous transplant was subsequently followed by 2 cycles of consolidation, and then they received 1 year of Len maintenance. So the primary endpoint was PFS, and the secondary endpoints were overall response rate, MRD, time to progression, overall survival, and safety. So this trial reported a significant improvement in PFS from 35 months with RBD alone to 47 months with transplant plus RBD induction and 1 year of Len maintenance. So the 4-year overall survival was not different between the 2 arms. So coming to the determination study, so this was a multi-center randomized open label phase 3 trial, which was conducted at 56 sites in the United States. So the patients with newly diagnosed multiple myeloma aging 18 to 65 years and having performance status of 0 to 1 were stratified by ISS and the cytogenetic risk, and they were randomized into the VRD alone arm versus the transplant plus VRD. So after 3 cycles of initial VRD, cycles of RBD were given, followed by continuous LEN maintenance. And in the autologous stem cell transplant arm, the 2 cycles of consolidation were followed by continuous LEN maintenance. So the basic difference between the determination and the IFM study were 1 year LEN maintenance in the IFM 2009 study, and the determination study which used continuous LEN maintenance until progression or intolerance. So the primary and the secondary endpoints were same. So what separated the IFM 2009 from determination trial? So it was the results of this CALGB trial, which was published in NEJM in 2012, led by Philip McCarthy. And this trial actually studied it established the role of continuous LEN maintenance versus placebo in patients who received autologous stem cell transplant. So there was significant improvement in median PFS from 27 to 46 months, and significant improvement in overall survival with the use of continuous LEN maintenance. So the inclusion criteria of determination trial, as I mentioned earlier, it included 8 patients who had age of 18 to 65 years with symptomatic measurable disease and performance status of less than equal to 2. The patients with the prior systemic therapy, amyloidosis, CNS involvement, severe cytopenias, or severe organ involvement were excluded. So a total of 722 patients were finally enrolled and underwent randomization, 357 in the RBD group and 365 in the transplant group. So out of the 365 patients who underwent randomization to the transplant group, close to 15% of the randomized patients who actually didn't undergo transplant. So this number was significantly less in IFM 2000 trial. So these are the basic characteristics. So both the arms were fairly balanced in terms of baseline characteristics. The median percent of the study population was constituted by Black patients, and the investigators actually received a lot of appreciation for this aspect of the trial because this actually reflected a lot of inclusiveness as far as trial enrollment was concerned. Majority of the patients had ECOG performance status of 0 to 1. As far as the distribution by ISS stage is concerned, about 50% of the patients in both the arms had ISS stage 1. Whereas if we look at the IFM 2000, this was one of the major differences between the 2 study populations. The high-risk multiple myeloma patients constituted around 20% of the study population, and RISS stage 3 patients were close to 9%. So the primary endpoint of the study was progression-free survival. So as you can see, the trial met its primary endpoint. So with the addition of autologous stem cell transplantation to VRD induction and LEN maintenance, there was significant improvement in PFS from 46.2 months in the RBD alone arm to 67.5 months in the transplant arm. So there was difference of 20.2 months between the 2 arms. If we compare it to the IFM 2009 study, the difference was the values were 47 and 35 months. So this was after a median follow-up of 76 months. So one of the major reasons why there was significantly more PFS in the determination study was actually the continuous LEN maintenance which was incorporated. And secondly, there were a sizable number of patients who were actually going off protocol to receive non-protocol post-hoc.
In between, you're losing your audio.
Am I audible?
Yeah, your audio is going off in between. I don't know.
Perhaps you could take off the video, then it will be okay.
Yeah.
Yeah, so I have switched off my video. Am I audible?
Yeah, you're audible. It just goes off in between, the patches.
Okay, I beg your pardon, sir.
No problem. No problem.
So, uh, are my slides visible, sir?
Very
Yeah.
much, very much.
Yeah.
Yes.
So, in the determination trial, so a sizable number of patients actually went off protocol without confirming progression to receive non-protocol therapies. So this was possibly one of the reasons that could have actually falsely prolonged the PFS in the determination trial. So that's why the investigators also did the EFS analysis. So in the EFS analysis, they considered those 47 months. So which was actually much lesser if we take it in the context of the trial. So with regard to the cytogenetic risk, both high risk and standard risk cytogenetic patients actually drew benefit from the transplant. The median PFS improved from 17 to 55 months in the high risk group, and in the standard risk group, it improved from 53 to 82 months. So the investigators also did the subgroup analysis to determine which group of patients actually benefited more. So the black population, which constituted 20% of the study population, they actually benefited less as compared to the white population. Secondly, the ISS stage 1 patients actually did much better as compared to the ISS stage 3. And thirdly, the high risk myeloma patients actually drew more benefit as compared to the standard risk population. So another aspect of the trial was the analyzing the outcome as compared to the MRD state, and it is associated with the outcomes. So if we look at the MRD negativity at the start of maintenance, so it was about 55% in the transplant arm versus 40% in the RBD alone arm. The patients who achieved MRD negative status had similar 5-year PFS survival, and it actually reflected that achieving MRD negative status, irrespective of the way you achieve it, that actually reflects in the prolonged PFS. Among the MRD positive group, the transplant arm actually did better with median PFS of 50.6 months versus RBD alone, which actually reflects the durability of the responses that we see with the stem cell transplant. So coming to the response and the duration of the response, majority close to 95, close to 100% of the patients achieved partial response or better, 50% achieved CR or better. The durability of partial response or better was higher in the transplant arm, and it was statistically significant. The overall survival was not different between the two arms, and the median OS was not reached in either of the arms. And the 5-year overall survival was close to 80% in both arms. So coming to the safety, there was no new safety signal. As expected, the grade 3 or more adverse events were more common in the transplant arm, with the predominance of neutropenia, leukopenia, thrombocytopenia, and febrile neutropenia incidences. The median duration of treatment was with LEN maintenance was more in the transplant arm, which was close to 41 months as compared to the RBD alone arm. And because of greater incidence of adverse modifications. So this was also an important aspect. Then one of the important, I would say, interesting finding from the determination trial was the incidence of second primary malignancies. So overall, the incidence was balanced close to 10% in both the arms, but the incidence of invasive and hematologic second primary malignancies was numerically more in the transplant arm, and there were 10 cases of AML MDS in the transplant arm versus none in the RBD alone arm. So the quality of life metrics were also studied, and as expected, the quality of life dipped during the transplant arm. It was clinically significant, but the quality of life improved as soon as the patients recovered from the transplant procedure. So coming to other outcomes, about 80% of the patients in the RBD alone arm received subsequent therapies. There was greater proportion of patients in the transplant arm who received DARA, and 28% patients in the RBD alone arm were actually able to receive delayed transplant. So this was much less as compared to the IFM 2009 protocol. So if I conclude the results of this trial. So for patients with newly diagnosed multiple myeloma, the addition of stem cell transplant was actually beneficial in terms of median progression-free survival. In the PFS was about 20 months greater in the transplant arm. The overall survival was not much different. The MRD negativity rates were greater in the transplant arm before the starting of the maintenance. And the patients who achieved MRD negativity had no significant difference in the 5-year PFS rate. And overall, the addition of stem cell transplant was tolerable. There were more side effects in the transplant arm, but majority of the patients were able to tolerate the same. There was signal for high incidence of hematological second primary malignancies, and the quality of life was inferior in the transplant arm. So if we put the results of the determination trial in the context, so first thing is that this trial shows that transplant is efficacious. It actually reflects in the PFS benefit, which is much greater as compared to the previous similar trials. And we have seen that stem cell transplant actually deepens the response, which is reflected in more incidence of MRD negativity rates. The lack of overall survival benefit could be because of the effective post-protocol therapies that these patients received. And the value of PFS benefit may be actually good enough for the patients to choose transplant, because 20 months, it is like close to 2 years of remaining disease-free in the transplant. Actually creates a kind of room for professional bias, because the transplant physicians may differ in their opinion from the non-transplanters. The transplant physicians may look at this data and say that there is less chance that the transplant may be feasible in the delayed setting, so do it early. The non-transplant physicians may say, we don't agree with you. There is no survival benefit, plus you are giving more toxicity. We might the majority of the patients might not actually need transplant. The third aspect is whether this trial is practice informing or practice changing. So when the trial was enrolling patients, the stem cell transplant was already the standard of care. So I don't think there was much change in the practice. It actually gives the opportunity to both the patients and the physicians to make informed choices regarding the selection or refusal for the upfront transplant. And in terms of practice changing, I think in the developed countries, it might add more weightage towards the flexibility regarding the timing of the transplant. So conventionally, we consider transplant as a part of upfront therapy, a kind of frontline intervention. But these results may actually suggest that delayed stem cell transplant may be actually feasible in a select group of patients who are young, who have standard risk disease. They may actually be treated in the setting of the clinical trial. And last but not the least, the most important thing that this trial reinforces is the role of lenalidomide as a continuous maintenance therapy. So the PFS benefit was longer than most of the previous trials. And we have seen that despite more dose modifications in the transplant arm, even the small doses were able to produce beneficial results when given for prolonged duration. So there are some caveats in the trial. So if we look at the comparison between the IFM 2009 and determination trials, so they were two different study populations. The IFM 2009 was conducted in Europe, mainly in French population. The determination trial was conducted in American population. there were significant differences in terms of the race of the patients who were included in the trial. Secondly, more patients in the IFM trial actually went ahead with the delayed stem cell transplant versus the determination study, and that could actually reflect the heterogeneity in the hematology practice in the two countries. Secondly, the median age in the trial is 55 to 57 years. So most of the patients were younger, healthy. In the real world, the median age, we have data from United States. And the results may not be generalizable to these patients. And as far as age is concerned, so for elderly patients, it might not be the question of early versus delayed transplant. So for somebody who is diagnosed close to 65 years, it might be the physician who is taking care of that patient might actually answer whether this patient is going to receive transplant or not. The question is not going to be early versus delayed, because transplant has a limited window. One cannot be transplant eligible for whole of his life. And we know that attrition is known to occur with subsequent relapses. So the feasibility of delayed transplant is hampered by various challenges, like I mentioned. The facility for long-term stem cell preservation might actually not my countries, and the insurance which some of the patients might not be having the cooperative insurance that might support am I audible?
How you are audible?
Extremely
Cut out
sorry.
there quite a bit.
Yeah. So I think I was discussing the feasibility of delayed transplant. So the challenges are the age, comorbidities, and performance status. So the presence of renal impairment or resistant disease at relapse is also another major deterrent for the delayed transplant. The facility for long-term stem cell cryopreservation might not be actually available in majority of the centers in lower middle income countries, and the appropriate insurance might be required. All insurance companies might not support the idea of delayed transplant, even in the developed countries. So if we look at the Mayo Clinic data from 2004 to 2015, among 1,500 patients who were studied, about 50% of the patients among those who were actually planned for the delayed transplant actually went ahead with the same. And there was inferior overall survival in this group of patients. So there are, in the real world, there may be several challenges regarding the delayed stem cell transplant. So if we talk about the role of high-dose melphalan and stem cell transplant in lower middle income countries, so we know that stem cell transplant is still underutilized. I can talk about our own center's experience. Only a small fraction of patients who have been diagnosed in the last 20 years actually went ahead with transplant. There are economic concerns and access to the newer consider the cost of transplant is close to $6,000, whereas the cost of 16 doses of DARA is close to 5 times the cost of autologous stem cell transplant, and cost of generic carfilzomib may be about $4,000 and the PFS benefit might not even reach close to what we achieve with stem cell transplant. And there have been increase in the number of transplant centers throughout the country. The sporadic expertise, which was earlier one of the limiting factors, might not be there in the coming years. So we have seen that the high dose melphalan and stem cell transplant might not be a favorite of the pharma companies throughout the world, but it has a broad fan base. And this is the impromptu poll of the popularity of determination trial as a positive trial in favor of stem cell transplant, which Dr. Philip Moreau asked in the recent IMS meeting. And as you can see, close to 70% actually said yes. So if we look at the future of the treatment horizon of newly diagnosed multiple myeloma, we might actually see more of personalized therapy, which is going to be the future of multiple myeloma therapy. Strategy as of now is not the standard of care. There is no phase 3 data, but there are very promising trials which are undergoing patient recruitment.
Aditya, since for the time concerns, can you wind up?
Yes, sir.
So we can have more
So
time.
the major challenges of stem cell transplant in the newly diagnosed myeloma patients may be bispecifics and CAR T cell therapy. There is a lot of enthusiasm about that around them. The quadruplet inductions and doublet maintenance may come to the fore in the coming years. And the question of early versus delayed stem cell transplant probably is not going to be clearly answered anytime soon. Thank you.
So may I invite Dr. Shaji and Dr. Pankaj to give some remarks. Basically, I was thinking a little more critical thinking on the methodology part. If you could highlight flaws, critically thinking on various aspects, maybe if you have to go by the consort, looking at the randomized study, critically appraising it. I would like to hear from you, both of you.
Sure. I think, Aditya did a really nice job highlighting some of the major issues with this trial. I mean, the biggest problem is obviously almost a 20-month difference between the EFS and the PFS in the study. And when you look at the EFS curves, you can see that a significant number of patients just went off study even before they went to transplant, 15%. And then there's a whole bunch of patients who didn't didn't continue with maintenance in the transplant arm. And that becomes, again, an issue. And I think there's a question in the Q&A. Someone asked about the PFS, EFS issue. And in fact, I think when you compare the IFM trial, it may be better to compare the EFS from the determination trial to the PFS from the IFM trial. And in which case, the numbers are actually quite similar. The second issue is the ISS distribution that was also highlighted. I mean, there's a lot more standard risk, maybe more indolent patients who actually gotten into the determination trial than in the IFM trial. So I think the two major issues from a methodological standpoint, and I think it's a issue that cuts across a lot of the trials that are done within the US. The people actually get taken off study for a variety of different reasons other than progression, just because of patient preference, physician preference, and just not the right way to do a phase 3 trial. So I think this trial suffers from the same issues as well. So I think, again, the whole question of, the duration of maintenance, is the 2 years better, worse than continuous, is not really answered by this trial at all. Pankaj.
So, I feel that, you cannot make a trial which is 100% perfect kind of a thing. So even though there are some fallacies, but still determination trial plays a very important, it's a landmark kind of a study, which has reignited, which actually has raised many issues, I would feel. So for the developing countries or low middle income countries, as Aditya has already highlighted, I would feel that transplant would remain as one of the treatment strategies for our patients who can undergo transplant, because it would be still be very cost effective as compared to many new medications which are coming up in the field of myeloma. So the good thing in India is that now there are a lot of transplant centers, a lot of people who are doing transplants, and we all know that myeloma is the easiest transplant, which in fact many people do not consider transplant as a transplant in myeloma. It is just a high dose chemotherapy only. So I feel that the role should increase, the role of transplant in the field of myeloma treatment in India would increase over a period of time. Whereas if you ask me, and Shaji can comment on that, in US, I'm not very sure what will happen to the field of transplant in view of coming up of CAR-T and bispecific treatment for myeloma, because Melphalan is nobody's baby. It is not any pharma's baby. So I'm sure that the pharma people are going to use or defame Melphalan based on the risk of AML, risk of MDS, which happens once you give Melphalan to these patients. So Shaji can comment on that. But in India, I feel that definitely the role of autologous transplant will increase, and it should be part of standard treatment for all those patients who are eligible for transplant. Thank you.
No, I completely agree. I think the determination trial, I think just as you pointed out, I think my read on that is that again confirms the role of autologous stem cell transplant despite all the deficiencies in how the trial, the trial conduct and how that might impact the results. One of the biggest questions, the criticisms that is brought up is that only 28% of the patients got transplant and still their overall survival was almost as good. But you also have to think about the fact that these are patients in their 55 to 65 age group. They're not going to die of myeloma during their second or third line of therapy. These are the patients who probably end up getting 5, 6, 7, 8 lines of therapy before they might die of myeloma. So it's very early to say that not getting transplant at the time of first relapse actually, that the impact on the overall survival should be taken as the reason for not to transplant. And I think the other thing too is, especially as we start using quadruplet induction therapy and potentially a doublet maintenance in the context of stem cell transplant, that 5-year PFS we might be looking at 7 or 8 year PFS. And now we are talking about patients who are, let's say, somewhere in that 60 to 65 year age group. They might no longer, there's a high probability that patients over 60 might not be able to get to a transplant, even if you collect and store. So I think we will be, depriving them of a therapy that is really effective. And as in myeloma, with all these different treatments are building blocks, one over the other. So taking off a huge building block of transplant and maintenance is probably not going to be good in the long run. And I think it's incumbent on the CAR-T trials to actually demonstrate some trend towards an improved survival, especially overall survival, or a significant difference in the PFS for us to be able to actually throw away stem cell transplant. So I think the early transplant is so cost effective, right? Because if you do an early transplant, one, you're saving on having to collect and store the cells for the delayed transplant. Two, it may not be as much an impactful in India, for example, with the cost of lenalidomide being low, but the cumulative dose of lenalidomide administered in the maintenance setting is actually lower post-transplant versus when you're not transplanted. I mean, due to a variety of reasons, but it's at the end of the day, it all factors into that cost of therapy.
So can I give you a contrarian view to discuss this for the discussion's sake? Let's for a moment talk against the transplant point of view. So we are seeing that the PFS is fantastic, OS is the same, and so there is some equalizers which is happening it is the salvage therapies which are coming in, second and the third lines which are coming in. If cost is not an issue for the third and if cost is an issue for the third and fourth line, there is a case for transplant to say that, okay, melphalan 6 to 8 lakhs is cheaper than daratumumab subsequently. So if you take the cost out of the equation, would you still go by? That's my first question to Dr. Shaji.
I would
Second-
still go with it.
You will
John, I
still
think
go.
the important thing is you think about it, right? I mean, if you have a young patient with myeloma is living for 15 years, the 6 years or 5 years out of that is coming from the transplant and the initial therapy. Maybe the 3 to 4 years from your next line of therapy, 2 to 3 years from the subsequent line, and maybe 1 to 2 years from the line after. So if you completely try to eliminate the transplant, you're taking a big chunk out of their effective therapies for the duration of the disease. Yes,
So-
you can give it later and recapture the impact, which is what the whole the debate is about. People who don't like transplants say we should never transplant. And people who favor transplants say we should give early transplant. Some of the delayed transplant concept is kind of disappearing in between, and which is often what happens for patients who don't get the early transplant is, even in the US where we collect the cells and keep it in the fridge, people forget about it and they never come back to get that delayed transplant.
So along with it, the question is, how much of a TRM is acceptable in myeloma transplant?
There's really zero TRM in myeloma transplant. I mean,
No,
hardly
so-
anybody dies of.
I mean, in US, no, but in India is not the situation. We deal with a lot of MRD bugs, which is there. It is still a possibility. It's not that it is not like
Yes.
we are stench free in AM myeloma transplant. So what do you think is a reasonable, acceptable TR?
I think you have to again think about it in the context of what is the pros and cons, right? So if you're talking about a situation or an environment where the access to that subsequent therapies are rather limited because of a variety of different reasons, then you probably are willing to take a slightly higher risk. And I think anything more than a couple % is probably not a good number, but again, you have to think about it in the context of other things post-transplant.
Oh, sorry.
yeah.
Go ahead.
So, Joseph, your question can be seen in two contexts. The first thing is in the field of myeloma, I would say, this is my personal, I hate relapses. I don't want to see any relapse. Relapse basically means that you have already, have the life is limited. Whatever drugs you have, whatever therapies you have. So I want to use the best therapy upfront in all patients of myeloma so that they don't relapse. And for that, we actually have to change our thinking in the sense that we should not consider myeloma as remission, relapses, remission and relapses. And this is again, my personal thinking that we should think like a lymphoma. You give 6 months of treatment in lymphoma, non-Hodgkin lymphoma, and you say, okay, 60% are cured, diffuse large B-cell lymphoma. Similarly, we also have to think like that you are curing majority of patients, curing in quote unquote, you are curing majority. There would be some patients who would relapse. That happens in Hodgkin's also. That happens in, CML also. That happens in other disorders also. But we have to change our thinking process. This is one. The second about the TRM which you are talking about. Now, if you look at the mortality in newly diagnosed patients of myeloma, and if you look at the Indian data, in the first 3 months, this is around 15 to 18%. I mean, this is a reality. We are talking of 15 to 18% mortality, either because of infection or because of other reason in newly diagnosed patients of myeloma in low and middle income countries. So, transplant, when you are doing transplant, and I'm sure now people who are doing transplants in their center, the mortality is less than 5%. In fact, I feel it must be 2%. What is the mortality at your center? It must be, less than 2%.
Correct.
We
This
did
is
not
just for
have,
discussion to
Yeah.
kind of understand the aspects.
I feel that mortality because of the relapse, mortality because the initial 3 months is too high than doing a transplant. So I would still favor doing a transplant and give the best form of therapy upfront in all these patients wherever they are eligible. Thank you.
So one more query. Could melphalan followed by lenalidomide have predisposed them to an AML MDS rather than len alone in the other arm? So should you worry about that part? You made a case saying that len will be lower dose, attributing the entire probability of a secondary malignancy to len, but could melphalan would have predisposed them to get an AML MDS situation?
Absolutely. I think the part of the signal is coming from melphalan, right? So I mean, if you look at the len maintenance trial, just 3% without maintenance and 6% with maintenance. So at least again, there is a contribution of both lenalidomide and melphalan. So I think you had to look at the spectrum of the second malignancies too, right? I think we are thinking about the 10 versus 0 being a big thing, but at the same time, if you look at the lymphoid malignancies, that was like 7 versus 2 or whatever the number was. I don't remember exactly, but the total number of malignancies isn't that significantly different between the two arms. Now, having said that, if these patients indeed do live longer than they have done in the past, are we going to see more second malignancies? And overall, if these people with myeloma are going to live an extra 5 years with increasing newer therapies, are we going to see more and more second malignancies in patients who have previously undergone stem cell transplant? It's really hard to know, but the CABMTR analysis clearly shows that even with accounting for the increased risk of second malignancies, most people still die of myeloma, not necessarily the second tumor.
Sure. There are 2 more questions from the audience. Before that, Aditya has raised his hand, so I'll give it to him. We have another 5 minutes to go, so we need to have quick discussion and then hand over to Dr. Dr. Aditya, please go ahead.
Sir, I have 2 questions for you. So while going through the literature review for the determination trial, the one thing that I could point out was why the investigators actually looked for MRD before maintenance in this trial instead of looking for it before transplant, because if we have not established MRD as standard of care in the induction, why to push it to the maintenance? And second, for patients,
your break now.
Centers in am I audible?
Ritik, can you type your question?
Yeah. So for the delayed transplant, should they be in the context of a clinical trial as of now, or will it be considered a standard of care in routine clinical practice?
So I think the reason for the MRD testing is, the CR rate with 4 cycles of injection is only about 35-40%. So the MRD rate is going to be actually more than 20%, and it will be very less informative at that point in time. And if you're already thinking, so there are 2 important questions, right? So one is, with a RVD injection therapy, MRD after 4 cycles can be very low. And really the question was to try and see, what is the impact of MRD negativity at the point of, where the 2 arms really converge in a way, which is the start of maintenance therapy. Now, that question can be asked after 4 cycles if you're using a 4 drug injection therapy or given for 4 to 6 cycles, which is the current trial designs that are ongoing, where they're randomizing patients based on that MRD status or stratifying them at the MRD status with and without transplant, to ask the question, which group does the transplant really benefit the most? And the second question, I think the key thing, I would say, based on the data that we have, the early versus delayed, I mean, it's been asked so many times, right? So I think either is acceptable, but clearly in high-risk patients, as you already highlighted, it's better to do an early transplant. And the standard risk, people are getting good response. If they want to delay transplant, fine. But again, I think personally, my preference is to do an early transplant where it's feasible and patients are willing.
Sure. So Dr. Ankit Jitani has asked 2 questions, and I think that has been answered just now on the MRD point of view. Sadanand Bounce has asked a question on why can't we use targeted therapy upfront, which can probably replace a bone marrow transplantation? You alluded to that in the early talk, but can you just answer that for the question's sake?
And again, I think there was some.
Okay.
The person also pointed out to the
why aren't we using targeted therapy upfront? If we can have plasmas, can you hear me?
Yep, you're fine.
Yeah, if
Yeah,
you can use plasma cells surface specific markers, I mean, suppose you get targeted therapy upfront, like DARA or any other, can we do away with transplant is the question as I understand it. Yeah.
Right. I guess that's a question. That's the focus of some of the ongoing phase 3 trials with the DARA VRD or DARA isatuximab RD combinations. There are a couple of trials out there which is really looking at transplant versus no transplant or early versus delayed approach with that induction therapy.
Okay. Any other questions? For renal involvement in myeloma, how much dose to be used? I think it is out of the context of this discussion. And I think because of time constraints, I would hand over the next session to Dr. Uday. Thank you so much, Dr. Shaji and Dr. Pankaj.
Thank you.
Thank you, sir. Thanks a lot for a wonderful discussion on the determination trial. And thanks to both the panelists and the moderator. Mr. Mayur, can we have the slides, please? So now the next part of the session would be introduction to our Eagle Eye competition. So we are launching in this particular session by Image a competition for the best commentary on the Journal Scan article. Now, can I have the next slide? So what's the process? Don't worry, the process is not very confusing as shown. So basically, firstly, we have an article chosen by one of our international faculty members on a recently published material on plasma cell dyscrasias. Next. So what you people are supposed to do is to send a commentary, a critical analysis of 175 words before the due date. We generally give you a time of 2 weeks to send us this commentary, and you will have to mail it to us. Now, who all can participate? Any JR, any SR, any faculty, not only from medicine or hematology or oncology, any specialty, because we all understand that plasma cell dyscrasias encompass multiple specialties. So any specialty with interest in plasma cell dyscrasias can send their commentary or critical analysis for this article. Next slide. So the selection will be done based on after going through all the commentaries. So 3 blinded reviewers from the Image EC or non-EC members will be going through all the commentaries, and then they will select, grade the commentaries and choose the best. And the gains would be, you'll definitely get a certificate, few credit hours from Image, because those who reach 100 credit hours, they will have some surprise prizes at the end of the year, and vouchers worth 5,000 rupees. And more importantly, you get an opportunity to present your journal scan in front of the international audience. Next slide. So the purpose is, as already illustrated by Dr. Joseph John in the beginning. So we want all of you to read the latest articles on plasma. Next. We want you to learn the art of critical appraisal. Next. Refine the art of scanning an article as soon as possible. Next. Writing letters to editors, because we want to encourage the students and the junior faculty from our country to write more and more letters to the editor. Get an opportunity to present in front of the international audience. And lastly, to have an inter-institutional competition like this here we got from certain institutes, and you can make out from the commentary that which institute is really doing very well as far as the journal clubs, their way of academics is concerned. So it's sort of an inter-institutional competition. Yeah, next slide. So this year, after we have gone through everything, so the winner for this year is Dr. Hari Krishnan P, who is an assistant professor. So congratulations, Dr. Hari Krishnan, for your commentary. And we will be playing his recorded video of the journal scan for the article that was sent by Dr. Shaji to everyone. Yeah, please go ahead and play the video, please.
A very good evening to the August gathering. Today, I will be presenting the journal scan on the article Teclistamab in Relapse or Refractory Multiple Myeloma by Moro et al., published in NEJM on 11th of August 2022. The existing standard of care in multiple myeloma encompass triplet therapy with an immunomodulatory agent, a proteasome inhibitor, and a corticosteroid. Numerous other combinations, including monoclonal antibodies, chemotherapeutic agents, are also in practice. Among more recent additions are the 3 BCMA-directed therapies, which include the antibody-drug conjugate belantamab and 2 approved CAR-T therapies. Non-BCMA alternatives with safer side effect profile are also available. There is a dearth of studies assessing the comparative efficacy between the BCMA and non-BCMA agents. Inter-BCMA agent comparisons are also scarce. Patients who relapse after the triplet therapy have a poorer prognosis with limited therapeutic options. Novel therapies such as BCMA-directed therapies have indispensable role in its management. Also, with a potential role as off-the-counter drug, teclistamab is placed suitably to counter the logistic challenges posed by other BCMA therapies like the CAR-T therapy. As a bispecific antibody, it targets CD3 on T cell surface and BCMA expressed on myeloma cells, and thus induces immune response against myeloma cells while it also inhibits the maturation of myeloma cells. This is phase 2 dose escalation open-labeled single-group trial wherein once-weekly subcutaneous injections of teclistamab 1.5 mg per kg were administered 4 days after the two step-up doses of 0.06 and 0.3 mg per kg. Cycles were of 28 days duration and were continued till end of study period of 2 years, disease progression or development of toxicity. An overall response rate, that is partial response or better, was the primary outcome with numerous secondary outcomes including CR, MRD negativity, overall survival, adverse events, etc. were noted in the study. The study included patients of both genders who had received at least 3 lines of prior multiple myeloma treatment including immunomodulatory agents, proteasome inhibitors, and anti-CD38 monoclonal antibodies with an ECO-PS not more than 0 or 1, and excluded patients with other forms of plasma cell neoplasms, medical conditions like stroke, seizure, uncontrolled systemic infections, or persistent toxicities related to prior anti-tumor therapy. Individuals who had received a cumulative dose of more than 140 mg prednisolone or equivalent or had received a live attenuated vaccine within 4 weeks of first dose of teclistamab were excluded. Coming to the results, the study had a poor representation of elderly and Asian population with a very low proportion of patients with high-risk disease. Also, although all the patients were triple-class exposed, only 77% cases were triple-class refractory, and any attempt to equate both should be discouraged. Among the 63% patients who achieved primary endpoint, around 40% had CR, 59% had VGPR, 32% had stringent CR. Also, a median overall survival of 18.3 months was noted in the study. Most notable aspect about this study is the safety profile, with up to 95% patients developing grade 3 or 4 adverse events. Safer alternatives will take precedence. This is a major setback to teclistamab-based therapy in multiple myeloma. Authors concluded that teclistamab resulted in a high rate of deep and durable response in patients with triple-class exposed multiple myeloma with a high proportion of adverse events. With relapsed refractory multiple myeloma being the condition under study, novel therapies with better logistics definitely is a step taken in the right direction. Certain limitations noted in the study were the high attrition rates observed in the first 6 months of the study. A high mortality rate of up to 41.2% from disease progression questions its role in relapsed refractory multiple myeloma. Also, with poor representation of Asian population, there is very little external validation. There is a dismal representation of elderly and patients with extramedullary disease. Also, most patients had a good ECOG-PS and belonged to low or moderate risk profile, and thus its role in cases with poorer prognosis remains unknown. Primary endpoint based on PR doesn't support authors' claim of deep response, and an outcome-based endpoint would have been preferable. High percentage of grade 3 or 4 adverse events tarnishes the role of the drug, more so in resource-limited setting wherein management of these adverse events can take a toll of existing healthcare settings. Thank you for patient listening.
So that was a presentation from Dr. Hari on the general scan. And now it's time for quiz. And we have Dr. Arun, who would be our quiz master for the day. So the quiz questions will be based primarily on the general club and the general scan, which were conducted, along with one trivia question. So over to Dr. Arun, please.
Good evening, everyone. Am I audible?
Yes.
Mayur, can I have the next slide, please? Yeah, so for the quiz, we have these rules of engagement has already been introduced. Two of them would be based on the Journal Club, two on the Journal Scan, and one would be on the trivia. The fastest finger with the correct answers gets an attractive prize. Can I have the next slide, please? So let's start with the trivia here. The National List of Essential Medicines was first compiled in 1996, and it was revised thrice earlier. 384 drugs find place in the newly released list almost a week ago. I want you to answer this question, that which of these myeloma drugs was added to the newly compiled list? Lenalidomide, pomalidomide, bortezomib, or carfilzomib? We move ahead from the trivia to the journal scan. In the just discussed MajesTIC trial, which of the following was not an exclusion criteria? Was it prior treatment with any therapy that is targeted to BCMA or any CD3 targeting redirecting drug? Somebody who has received an autologous transplant within 24 weeks before the first dose of the study drug? Was it plasma cell leukemia or myeloma with CNS involvement? The next question, based on the journal scan, which of the following is incorrect with respect to teclistamab induced CRS as per the results of the MajesTIC trial? Any grade CRS occurred in 72% cases. Most CRS events occurred after step-up and cycle 1 doses. 2 patients discontinued teclistamab due to CRS in the trial. And regarding CRS treatment, so tocilizumab was used in 36%, steroids in 8%, and a single agent vasopressor in less than 1%. We have now 2 questions from the determination trial. In the determination trial, which of the following was not considered a time point for bone marrow aspiration for response assessment and correlative analysis? Day plus 100 post-transplant, day 1 of RVD cycle 4, prior to LEN maintenance, annually during maintenance in consenting subjects. The last question. Originally, the determination study was planned to be conducted together with the IFM with a planned sample size of 1,000. However, a landmark research finding X led to protocol revision twice, and the sample size could be reduced to 720. What was X about? Favorable PFS hazards ratio with indefinite LEN maintenance, PFS benefits of early autologous transplant, PFS benefit of triplet or doublet induction, or was it to do with the deep and sustained MRD negativity with high-dose melphalan-based autologous transplant? Shall I go ahead and discuss the correct answer, sir?
Please do, please do.
Yeah, can I have the next slide, please? So this is what is published almost every 4th year or 5th year in our country, and this is the national list of essential medicines that's compiled by the government by a team of experts. And this year we have LEN entering the list. Bortezomib had entered the list the previous revision. I think pomalidomide and carfilzomib would have to wait. And once a drug enters the list, I think the access to the entire public as a whole is improved many a fold. Next question, please. This was the question regarding the MajesTIC trial, and the question was, which of the following was not an exclusion criteria? So the correct response was the autologous transplant within 24 weeks before the first dose of the study drug. Others were exclusion criteria. Next. So regarding cytokine release syndrome, which is actually a major point of contention when we use teclistamab, grade 1 or 2 CRS would actually be there in almost every patient, 2/3 of them or more. But the point to be noted is grade 4 or 5 CRS events are far few. And in fact, there was no discontinuation of teclistamab in the trial due to CRS. The next. In the determination trial, multiple times bone marrow aspiration was done as a part of response assessment, MRD assessment, and correlative analysis. Conventionally, we have been doing day plus 100 marrows for MRD assessment, but as per protocol here, it was day plus 42 here and not day plus 100. The last one. So what actually was a landmark research finding and that led to a revision of the protocol twice was the benefit of indefinite len maintenance and the favorable PFS hazard ratio, which was brought out by research, and that actually reduced the sample sizes by almost, I would say, 1/3. So the correct response is the favorable PFS hazard ratio with indefinite len maintenance actually led to a sample size revision in the determination study. Thank you all.
Thank you, Dr. Arun, for that wonderful quiz and doing a great job as a quiz master. I really doubt if I could have got all 5 answers right. Okay. But anyway, yeah, Mr. Mayur, can we have the next set of slides, please? So I'm coming to the end of the story for the day. So next month, we are going to have on the 4th Thursday, as every month, we are planned for this Journal Club and Journal Scan. So the next month, 4th Thursday would be 27th of October. Next. Mayur, click next, please. Yeah, 27th of October, next at 5:30 p.m. And we are going to have, Mayur, please keep clicking. Yeah, 5:30 p.m. And we are going to have it from ACTREC TMC Mumbai, who will be hosting the next Journal Club. The first inaugural one was by the best institute in our country, in no uncertain terms, because I'm an alumni of the same institute, PGI MER. So, but the next one would be from ACTREC. So let's see how they would do it in comparison to PGI. And the national panelist for the next month would be none other than our Dr. Naveen Khatri, the most dynamic and the young and most bubbly executive member of IMAGE. The article which would be discussed would be comparison of Lendex continuous therapy versus dose of schedule adjusted Lendex. So in this, we are going to discuss about doing away with dexamethasone and tapering the doses of Len. Does it make a difference for those patients who are elderly or intermediate fit patients? So this was one of the landmark trials and it has got a huge relevance for our country. So this will be discussed next time in the Journal Club. As far as the Journal Scan and the Eagle Eye competition is concerned, we are going to mail you the article very soon and we'll also give you the deadlines for that. We'd want more and more students and faculty to participate in the Eagle Eye competition. Next slide, please. The participation for the day. So Mayur has come out with some statistics from Mice Ideas. So total invites sent 1,800. We had 144 participants, 42 institutes in this country, international participation from these many countries. And I would like to specifically thank certain people. Yeah, can we have it in the slide viewer, please? Yeah. One second, Mayur. One second, just go back. Just go back. Go back. So anyway, I'd like to thank all the, particularly the international participants. For this, I would like to specifically thank Dr. Pankaj for spreading the word between the SAARC countries. So he has taken an effort to talk to each one of them. I would also like to thank my IDEA group of 2016, wherein we have got doctors from Azerbaijan, Nairobi, and from Mauritius, who have really helped to spread this word across the world about this Journal Club. So we are going to look forward for more and more international participation in the future. In fact, I have got 2 queries now on my WhatsApp, wherein they have requested, can they be doing the Journal Club? Yes, certainly. We would like to give this opportunity to the international institutes as well. So whoever would like to volunteer for it, we'll put it up to our executive members and to our president. And if they accept it, so we'll go ahead with it. So can we have the results now for the quiz? Yeah. So we have the fastest finger, Dr. Pankaj Patil. From which institute, Mayur? Any details? So he has won the quiz. So congratulations, you'll be getting a certificate. You'll be getting some credit hours from Image, as well as you'll get an Amazon voucher worth 2,000 rupees, which will be mailed to you within the next 24 hours. So before I close, I would like to pay my gratitude to the following people. Can we have the slides, please? Yeah, next slide. So the reviewers for the Eagle Eye competition, the blinded reviewers were Dr. Jeevan from TMC Kolkata, Dr. Bhausa from TMH Mumbai, and Dr. Arun from PGI Chandigarh. Next slide. Now, these are the three musketeers who head the scientific or the newsletter subcommittee, of which the person in the center has been really instrumental in rolling this program. Thank you, Joseph sir, for making this happen. Next slide. Now, nothing is without support from the rest of the members. So these are the other executive members who stood behind as a backbone for the complete activity, giving their ideas at every moment, particularly Pankaj sir, thanks to you in person. Next slide. And the most important, Dr. Shaji. He has taken the effort to select the articles, spare his time. We have been disturbing him right, left, and center at all odd hours possible. So thank you, sir, for being with us and making this thing happen. Hope this particular event percolates through different parts of the world and people develop interest towards plasma cell dyscrasias or dysproteinemias, as you call in Mayo. Next slide. So I would like to say goodbye. And if the president or Dr. Shaji or Dr. Joseph John has to add anything before we close, so I'll just give a minute to them before we close our event. Thank you, sir.
I just want to say congratulations to everyone for making this happen. It looks like it's definitely be a great success here with so many participants. So hopefully it'll keep growing.
So I would say that, this is so, we were waiting actually to start this, and now we feel that it should not stop, but obviously this is an hour and a half. And Uday, you actually did all the work. So I would say 3 cheers for you for all the things which you have done behind the scenes. And I'm sure you would continue to do that. So our all appreciation and congratulations for the same. Thank you.
So thank you, Uday. So I wanted to say that he is a turbocharger behind this. Without him, we could not have done this. Thank you. Thank you all.
So
we'll all see you next, we will all see you 27th of October.
Sure.
Yeah.
Thank you.
Thank you. Thank you. Take care.
So thank you, Mice Ideas, for doing this and for doing a wonderful event management for this particular thing. So hope we'll have a better and better events in the future with no technical glitches. So thanks a lot. And so with the permission of the president and Dr. Shaji and Dr. Joseph, the chair of the subcommittee, can we close this event, please?
Yes, please.
Thank you.
Thank you.
Bye.
Thanks.
Thank you. Bye-bye.